So hello, I'm going to be speaking about the versatility of clinical applications of the Pioneer Plus catheter in chronic total occlusion, True Lumen reentry in the periphery. Chronic total occlusions in the periphery are present in about 40% of patients with peripheral arterial disease, and many of these occlusions are long and complex. And the primary difficulty in crossing CTOs is the ability to re-enter the true lumen after subintimal crossing of the occlusion. With our standard guide wire and catheter techniques, our failure rates, at least in experienced hands, is about 15 to 20%. So in majority of cases, we can cross with the guide wire and catheter. However, when we fail, it can be extremely difficult to get back into the true lumen. And utilizing, standard guide wire and catheter techniques for prolonged amount of times can result in increased radiation exposure. There's certainly the risk of perforation as well as propagation of the dissection, which can result in associated loss of collaterals and which can be problematic for the patient. Reentry devices allow for a controlled true lumen reentry, which will increase the technical success rates in these complex cases. The Pioneer Plus catheter is a 6 French sheath compatible device which utilizes a 24-gauge needle to allow for re-entry back into the true lumen with an 014 non-hydrophilic guide wire. And I want to stress that a non-hydrophilic guide wire is key because you can actually strip a hydrophilic coating off of a standard guide wire. It has a very flexible shaft which allows for utilization via a crossover or contralateral approach. And the needle can be adjusted at needle depths of 3 millimeters, 5 millimeters, and 7 millimeters. So that allows for a lot of flexibility. The needle and the IVUS transducer are shown on this slide here. And the needle exits the catheter approximately 7 millimeters below the intravascular ultrasound transducer. So that's an important thing to know. The catheter length is 120 centimeters, and there's an integrated 20 megahertz IVUS transducer incorporated into the device. The Pioneer Plus catheter is a dual wire system, and this is a very important distinction compared to some of the other devices that are available, specifically the Outback device, which only utilizes a single wire. And this dual wire system has a tracking wire, which is the wire which is utilized to access into the subintimal tract, which is an 014 guide wire, and then a re-entry guide wire, and that's the non-hydrophilic 014 guide wire that we mentioned on the previous slide. And this is the wire that actually is utilized to go through the needle, which acquires true lumen re-entry and back, upon which further interventions are performed. This next slide demonstrates a video here, again produced by Volcano on utilization of the Pioneer Plus catheter for re-entry in the periphery. So this is a model of a chronic total occlusion here in the periphery. So initial attempt is made to try to cross this chronic total occlusion with a standard guide wire. However, you can see that this is not possible. So the guide wire then enters the subintimal space here, and this is followed by placement of a guide catheter to this location. The 035 guide wire is then exchanged for an 014 guide wire. And then the 014 guide wire, this is the guide wire upon which the Pioneer Plus catheter is advanced to the site of re-entry. Then we utilize intravascular ultrasound here, and we want to guide the true lumen, which you can see pulsating in red here, to the 12 o'clock position by rotating the device. And then you want to determine how long of a needle throw you want to achieve. And you can measure that on the intravascular ultrasound image, and then adjust the catheter to either 3, 5, or 7 millimeters. And then the blue handle is then advanced forward, and that pushes the needle forward. And finally, the non-hydrophilic 014 guide wire, the second guide wire, is advanced through the needle and back into the true lumen of the vessel. At this point, it's very important after you achieve true lumen reentry that you pull the needle back, because if you don't pull the needle back, you're going to injure the vessel on the way out. The device is then removed, And then this is typically followed by placement of a small balloon across the site, and then advancement of a 035 guide wire, an 035 catheter to this location. So next slide again summarizes those steps that we went through on the previous animation slide. Again, use the Pioneer Plus to be advanced over an 014 subintimal guide wire. The intravascular ultrasound is then utilized to target the True Lumen, and the device is turned to the 12 o'clock position. The needle is then deployed. A non-hydrophilic guide wire, which is 014, is advanced back into the True Lumen. The needle is retracted and the Pioneer catheter is removed. Then angioplasty is performed with the subintimal tract, and the remainder of the procedure is then carried out. And I'll get into that in a little bit more detail in the coming slides. So the first case I would like to present is a 69-year-old gentleman with a Rutherford 3 lifestyle-limiting claudication. Past medical history significant for hypertension and coronary artery disease, and the patient has a smoking history of about 30 pack years. This next slide here demonstrates angiogram which shows an occlusion of the right superficial femoral artery. You can see that there's a very small proximal nubbin. The image on the right demonstrates the long extent of the occlusion in the right superficial femoral artery. The left leg has previously been treated. So in this case, we initially tried to get across this occlusion via an intimal, through the standard intimal approach. However, given the long length of this lesion, and as often will happen, the guide wire and catheter ended up passing into a subintimal tract. So we, in this case, our standard approach is when the wire goes into a subintimal tract, we use either a glide wire or a roadrunner guide wire, which is doubled on itself in conjunction with a support catheter to cross through the subintimal space. Subsequent angiogram is performed once we're close to the site of our True Lumen reentry, and as you can see on this slide, on the angiogram, the doubled over guide wire is now at the site of the arterial reentry, the True Lumen reentry, I should say. Next slide now shows advancement of the Pioneer Plus catheter over the 014 guide wire to the site of True Lumen reentry. At this point, we're looking at the intravascular ultrasound image, and again, we want to focus on this red pulsating artery, which is the True Lumen of the vessel. And again, the Pioneer catheter is rotated until this pulsating artery is placed into the 12 o'clock position. You can see that there are marks here, which are 1 millimeter marks, and if you count the 1 millimeter marks from the center of the Pioneer catheter, you can see that the center of the True Lumen re-entry is 3 millimeters away. So in this case, we want to adjust the Pioneer catheter to 3 millimeters to achieve re-entry back into the True Lumen. These next images demonstrate firing of the needle and subsequent advancement of the 014 guide wire back into the True Lumen. And when the wire's in the True Lumen, the wire will pass very easily and smoothly without any resistance into the True Lumen. This is followed by angioplasty of the subintimal tract, typically with a 3 millimeter or 4 millimeter balloon. And the main goal in doing the subintimal angioplasty is to subsequently advance a 035 catheter over the 014 catheter, over the 014 guide wire back into the True Lumen, as most of these SFA interventions are performed over an 035 guide wire. So once an 035 guide wire is in place, then subsequently angioplasty and or stent placement may be achieved, as shown in this next slide, where a SFA stent is placed across the occlusion. And then subsequently an angiogram is performed, which shows a good result. And then finally another SFA stent is placed to the origin of the SFA, with the final angiogram demonstrating an excellent angiographic result. The next patient I would like to present is case number 2, a 75-year-old man with ischemic breast pain and a non-healing ulcer of the right great toe. Past medical history is significant for diabetes mellitus and coronary artery disease. Past surgical history is significant for prior recanalization and stenting of the right external iliac artery, with no improvement in the patient's ulcer. This slide demonstrates this non-healing ulcer on the first great toe of the right foot. The patient initially had a CT angiogram, which is shown here, which shows significant calcification in the aortoiliac segments as well as the superficial femoral arteries, really making evaluation of the arteries suboptimal, and the amount of stenosis is not well delineated here. Here are the initial aortograms which were performed on this patient. And the relevant findings here are the patient has a occlusion of the left common femoral artery. Also, there is a right superficial femoral artery occlusion with a small nubbin noted at its origin. So this makes this patient difficult to treat, as the occlusion of the left common femoral artery prevents a contralateral approach, and the proximal right superficial femoral artery occlusion prevents an antegrade approach, as there's not a lot of running room. So what are our options here? We can consider an upper extremity access. However, currently devices are not long enough to get down from a brachial or radial access, except maybe in a very short patient. Alternatively, what we chose to do in this patient was to perform a popliteal access. So these images again just demonstrate the long segment right superficial femoral artery occlusion. The subsequent image demonstrates access of the right popliteal artery, which was performed under ultrasound guidance with subsequent placement of a 6 French sheath. Initial angiograms were performed through the 6 French sheath within the right popliteal artery, which shows that there is a good at least 3 vessel runoff to the right foot. So the next slide here demonstrates advancement of a guide wire and catheter. As you can see, there is significant calcification in the superficial femoral artery, which was shown on the prior CTA images, as well as on these fluoroscopic images here, which resulted in the guide wire and catheter going subintimal. So in this case, a stiff-angled guide wire and a quick cross catheter were able to cross into the subintimal tract all the way up to the origin of the SFA, which was patent. In this case, you can see on this next slide here that the Pioneer Plus had a very difficult time crossing across this heavy calcification, which can be problematic. Calcification is problematic in many ways, and this is one of the ways where it may manifest, where the device will not pass. So what we do in a situation like this is we'll initially perform angioplasty of the subintimal tract, and this can be done with a small small 3 millimeter balloon to help advancement of the Pioneer Plus catheter. You don't want to use too large of a balloon, because if you end up creating too large of a subintimal plane, then the needle from the Pioneer Plus might not be long enough to re-enter the True Lumen again. This next slide subsequently shows advancement of the needle and subsequently placement of the 014 guide wire back into the True Lumen. And that is also demonstrated in the intravascular ultrasound images to the right, where the device was turned such that the True Lumen is in the 12 o'clock position. A subsequent angiogram was performed following True Lumen re-entry, and the main aim here was just to confirm that we're back in the True Lumen, which is typically obvious, as the guide wire will pass quite easily, but you always want to confirm True Lumen re-entry before performing any further intervention. And then this patient subsequently underwent stent placement via the Popliteal approach. And final angiograms are demonstrated here, which shows a widely patent superficial femoral artery with runoff all the way to our reentry site. The little filling defect you're seeing in the lower popliteal artery is actually just calcification. It's not a true filling defect, and there was no embolization during the procedure. Subsequent pulse volume recordings demonstrate marked improvement in the waveforms in the right ankle compared to before treatment. And most importantly, the patient healed the right toe ulcer approximately 4 months after this intervention, so this was a great success. Now we'll move on to case number 3. This is a 66-year-old white man with a history of left thigh and calf claudication, which occurs after 1 block, and which was lifestyle limiting. Patient's past medical history was significant for hypertension, atrial fibrillation, hyperlipidemia, and chronic kidney disease. Past surgical history is significant for a known left common iliac artery occlusion with a prior right to left femoral to femoral bypass graft, which is chronically occluded. Patient is a smoker as well, with 30-pack year history. Subsequent arterial non-invasive examination was performed, which demonstrates moderate to severe arterial insufficiency in the left lower extremity with exercise, with an ankle brachial index of 0.42 after exercise. Pulse volume recordings demonstrate diminished amplitude of the high thigh waveforms compatible with inflow disease. Ultrasound demonstrates an occlusion of the left iliac artery, and there's monophasic waveform in the left common femoral artery, which is a post-obstructive waveform. Patient then had a CT angiogram, which again confirms occlusion of the left common iliac artery. However, there is reconstitution of the distal left common iliac artery, and there's patency of the left hypogastric artery and the left external iliac artery. Patient was then brought for angiography, and as you can see, angiography was performed via a right femoral approach, and there's also a guide wire in the left external iliac artery, which again shows the extent of the left common iliac artery occlusion, which coincides with that seen on the CT angiographic images. So initially, a recanalization attempt was made with a guide wire and catheter via the left femoral arterial access. However, despite multiple attempts, the guide wire and catheter ended up going into a subintimal channel, and we could not cross the occlusion via an intimal approach. Next, an attempt was made to try to cross the occlusion via an up and over crossover approach from the right common femoral artery. However, enough pushability just could not be achieved via this approach, so this had to be abandoned as well. So finally, as you can see on this next slide, we decided to utilize the Pioneer PLUS catheter via a subintimal approach from the left groin, as standard guide wire and catheter approaches were unsuccessful in achieving entry back into the true lumen. So we achieved access into the a false lumen, and a Pioneer catheter was subsequently advanced over an 014 guide wire. This video clip here demonstrates, again, putting the artery in the 12 o'clock position. And sometimes you get lucky, as you can see here, when we fire the needle here, you see that echogenic focus at 12 o'clock when the needle was fired. You don't always see that, but when you do see that, it is very reassuring that you know exactly where the needle was fired. And this was followed by advancement of an 014 guide wire back into the true lumen, which passed very freely. Again, we always want to inject contrast back into the true lumen to confirm that we are in the true lumen before we perform any arterial interventions such as angioplasty or stent placement. And finally, this patient had placement of an 8 millimeter by 59 millimeter ICAST covered stent in this left common iliac artery with a subsequent angiogram showing an excellent angiographic result, and most importantly, there was no residual pressure gradient. Patient's symptoms resolved, and on post-intervention non-invasive imaging shows a normalization of the ankle brachial indices and normalization of the pulse volume recordings, and now there is a triphasic waveform in the left common femoral artery. A very successful result here. Next patient I'd like to present is a 75-year-old man who presents with non-healing ulcer of the left, second, and third toes. An endovascular intervention was attempted at an outside institution but had failed. CT angiographic images demonstrate marked calcification in the bilateral superficial femoral arteries as well as the tibial arteries. Initial angiogram demonstrates a short segment occlusion of the left tibioperoneal trunk as well as multifocal disease within the tibial vessels, including the anterior tibial artery. Initial attempt was made at recanalization of this tibioperoneal trunk occlusion with the standard guide wire and catheter technique. It's a very short segment, and we thought it would be very easy to cross with a standard guide wire and catheter. However, we were unsuccessful in achieving true lumen reentry with our standard catheter techniques and ended up passing into a subintimal tract. As a result, we decided to utilize the Pioneer PLUS catheter. One of the problems here was that, as we said, that calcification can make it hard to track the Pioneer PLUS catheter, but another problem with calcification in vessels is it is sometimes difficult to actually see the true lumen color flow, as the calcification causes significant shadowing artifact, which prevents you from successfully seeing the color flow. However, with some manipulations, and utilizing fluoroscopic imaging as well, the Pioneer PLUS catheter was successful in achieving reentry into the tibioperineal trunk, as shown on this image here, and the 014 guide wire was advanced into the tibioperineal trunk. This was followed by subintimal angioplasty of the tract and placement of a 3.5 millimeter coronary drug-eluting stent in this location with an excellent angiographic result. There are multiple studies have shown that coronary drug-eluting stents are effective in the tibial arteries. Subsequent pulse volume recordings demonstrate a marked improvement in the waveforms in the toes of the left foot, and this patient finally healed his ulcers about 5 months later after the intervention with wound care as well. In our experience, the Pioneer PLUS catheter has a lot of advantages over competitive reentry devices available on the market. The first and the most important is the ability to utilize real-time intravascular ultrasound guidance, which eliminates the guesswork. It's very easy for even a very inexperienced user to identify the pulsating artery on the intravascular ultrasound, put it in the 12 o'clock position, and achieve reentry back into the true lumen. Second, the needle is adjustable to 3, 5, and 7 millimeter lengths, and you could adjust the actual lesion length on the basis of the intravascular ultrasound imaging. Sometimes you end up with a large subintimal tract, and the large needle advancement up to 7 millimeters allows you to achieve true lumen reentry, which is not possible to this length with some of the competitive products. Third, the device is very easy to track over a steep aortic bifurcation, so a crossover technique can be utilized easily. The dual wire system certainly has its advantages as described previously, and most importantly, a different brand new guide wire is utilized to achieve true lumen reentry with the Pioneer PLUS catheter. One of the competitive products utilizes the same guide wire, which is utilized to achieve subintimal tracking of the device to achieve true lumen reentry. And the problem with utilizing a single wire is this wire is often damaged and ruined in the process of advancing the reentry device. Typically utilizes only a single stick controlled reentry. Again, there's no guesswork here. And finally, there's a potential for less contrast during the procedure and potentially a shorter procedure with utilization of the intravascular ultrasound. Next, I want to talk about some technical pearls in troubleshooting that we sometimes will encounter when we're doing difficult and complex peripheral arterial disease cases. First is a steep aortic bifurcation. Sometimes if you have a very steep aortic bifurcation, it can be difficult to get the device up and over a 6 French sheath. And what we utilize in this type of case is to upsize the sheath to 7 French. You could even go to 8 French, although we haven't had to do that. And this will usually take care of this problem. An alternate approach is to utilize an antegrade approach, which will eliminate the aortic bifurcation altogether. Second, as we showed on one of the case examples, the device will not track due to significant calcification. The thing to do here is to angioplasty the tract with a 2 or 3 millimeter balloon, and the key is to not overdilate, as this can compress the true lumen and also make the subintimal space too wide, which might prevent the needle from re-entering the true lumen. Finally, the re-entry site is something that we want to really keep an eye on, and we ideally want to re-enter at a site that's not calcified, although that's not always going to be possible, as showed on our last case example. And it's also important to choose a healthy artery as proximal as possible, as you don't want to extend the dissection too distally, as this can compromise some important collateral vessels. Clinical data is the next thing I want to talk about. There was a study that was published in 2009 in the Journal of Invasive Cardiology, where they looked at lesions with an average occlusion length of 10.7 centimeters. However, lesions up to 30 centimeters were included. So this is real-life type of cases. And lesions were both in the superficial femoral artery as well as the iliac arteries. And the success rate of subintimal re-entry with the Pioneer device was 95%. There was one complication which was not related to the Pioneer. It was one patient who developed a dissection distal of the re-entry site, which was successfully treated with an additional stent. What about cost effectiveness? Well, there's very little data on cost effectiveness, and so I can't present any data. However, in our experience, as we previously stated, up to 80% of chronic total occlusions in the peripheral arteries can be crossed with the standard guide wire and catheter techniques. So we don't need to utilize a re-entry device in every case. So a standard guide wire and catheter is very cheap. Utilization of crossing devices, which a lot of companies are advocating, adds a significant cost to a case from the get-go. But when we utilize the Pioneer device in the way that we're talking about here, where we only utilize it in about 15 to 20% of cases where we cannot cross the occlusion with a standard guide wire and catheter, we're not adding additional cost to the procedure from the get-go, and we're only adding the additional cost of the Pioneer device when it's absolutely necessary and when it's required to achieve a successful result. So selective utilization of the Pioneer Plus, which will achieve subintimal guide wire passage and which will necessitate a true lumen re-entry, would really be much more cost effective than utilizing a crossing device in every single case. So in conclusion, the Pioneer Plus is very easy to use and allows for treatment of chronic total occlusions via subintimal approach, and allows for treatment of more complex cases, including TAS C and D lesions. Technical success in our hands is between 95 and 100%. It is ideal to limit the extent of dissection beyond the occlusion and preserve important collaterals, and this can be very well done with controlled utilization of the Pioneer catheter, which will result in an overall decreased length of the treatment zone and reduce procedural time, radiation dose, contrast use, and utilization of ancillary devices. Thank you very much.